Okay, so good evening once again. My name is Bernadette Kyoheirwe. Welcome to this webinar. We are going to start right now. Our topic today is COVID-19 infection prevention for the health worker. We're going to have a presentation followed by a question and answer session after. You can post your questions in the Q&A part. It should be in the top right side of your screen. Just post your questions there or note them down somewhere to ask them later. You'll not be able to unmute yourself in this setting, but you can ask questions in there and or raise your hand later if you want to ask a question and you want us to hear your voice. That will also be okay. Okay, so our presenter today is Dr. Rodgers Ayebare. He is a sepsis clinician, an infection preventionist, and infectious diseases scientist. He is currently working as a program coordinator for medical countermeasures at the Global Health Security Department of the IDI. Rodgers has 4 years experience in advanced infection control practice, in-service healthcare worker training, and capacity development for clinical research during outbreaks, an outbreak such as this one. He has served as a member of the National Task Force at the Ministry of Health in support of infection control and infectious disease case management for re-emerging pathogens, including Ebola and COVID-19 since 2018. He also holds certification in infection control and epidemiology and is an active member of the Association of Professionals in Infection Control and Epidemiology. I don't think we could have found a better person to talk to us about this today. So Dr. Rodgers, thank you for honoring our invitation. And please start your presentation as soon as you're ready.
Thank you so much, Dr. Kyoheirwe, for the kind introduction.
Sorry, Rodgers, I want to have to interrupt you a bit. I see someone in the chat said they can't hear.
Hello, can you hear me now?
I can hear you. I don't know if the participants can hear you. Someone please just type a message in the chat if you can hear us.
Let us know if the audio is clear.
Okay, so someone says they can hear. So Ken Tomanya, it might be you. Sorry. Okay, sorry, Rodgers.
No worries. Thank you for the kind introductions, Bernadette. And I would also want to take this opportunity to thank all the healthcare workers who have made an effort to attend this webinar. And I would like you to know that your contribution supporting the health system during these tough times is duly noted and appreciated. So thank you, and thank you so much. So I will keep my video off during the presentation so that we are able to focus on the material, and then I'll put it back on for the Q&A session. So please do keep the questions coming in due course so that we can have a fruitful deliberation at the end of this presentation. I would also like to inform the attendees that I have no disclosures to make. So I'm sharing my professional opinion as well as what the current science recommends. So for some of you who might drop off the call later in the next hour, these are some of the key messages that I hope to put across over the course of this presentation. So the first one is that infection control starts way before you come into the healthcare setting. It begins as soon as you wake up in your home, and regardless of the route of transmission of majority of the infectious diseases, including COVID-19, proximity is a key factor that cuts across all the different modes of transmission, meaning you being in an environment where you are close to someone who is infectious is a risk factor for all the other transmission dynamics to come into play. And also personal protective equipment, which is the tool as healthcare workers we use in order to provide care, is one of the least effective measures in IPC, so much as the discussion will center around PPE for healthcare workers. We need to be cognizant by the time we get there, then multiple things have failed along the way before we get there. Then the last element is to do with personal risk perception and behaviors, that these have to be in agreement with the proposed recommendations for IPC and healthcare worker safety to be optimized overall. So I wanted to start my presentation with this video from New England Journal of Medicine, YouTube channel, where they show an ultra slow motion scaring video of what happens when someone coughs. So this video is not per se showing the flow of particles or germs, but basically how airflow changes around your nose and mouth when someone is coughing. And as you can see, the air moves quite a distance from the cough until, due to the different densities in the air, some of the air will go down to the floor, while the other will remain suspended in air and will be carried forward depending on the air current where this person is coughing from. And this will form a basis of majority of the measures that we are going to discuss, or the efficacy behind some of the IPC measures that have been proposed for practice in healthcare. So I'll play it for another 10 seconds, then I'll move to the next slide. So that said, COVID transmission is a bit complex because being a respiratory virus, we always have, let me see if I can get a pointer. Good. Yeah, so someone who is infected with the virus will be actively, coughing or releasing the virus in form of droplets, which are denoted by these significantly bigger dots, or even finer droplets that we call droplet nuclei, which are in this other finer print, which you might not be able to see. And if you can't see it, well and good, because they are really quite microscopic. So if this person is shedding virus in an unprotected manner, then these droplets or these tiny droplet nuclei will be suspended in air, and then a susceptible person can actually inhale them, and then infection can begin. The other mechanism is that because these droplets are also quite small, if you're coughing or sneezing in a dry environment, they will rapidly dry up, losing their water content, and you will have a smaller concentrated version of that drop with all the pathogens being carried in the air, and that will also cause infection in itself. But the one other critical route is through our hands, especially as healthcare workers or members in the community. If we cough or sneeze in our hands, then we are going to have all that contamination on these hands. And hands are a critical bridge between ourselves, the people we interact with, and our environment. So meaning if I cough onto my hands, and then I contaminate the environment where I'm staying or the environment which I'm sharing with other people, those people can actually pick up that contamination and then inoculate themselves in the eyes, in the nose or mouth. Or if this person is coughing recklessly, if I may use that term, then the environment where they are staying, as you saw in the other video, you'll end up having that contamination settle on the components of that environment, which could be the bed, could be the chair, or could be the medical supplies, and hands can also still pick it up from there. So basically, it is a mixture of your hands and also the respiratory secretions which you produce as projectiles in the air that can actually soil the environment or go on to infect people if they inhale them directly. But majority of us, we normally think of infection control when we are in such a situation, meaning we think IPC is the measure once the threat is already holding the gun to our heads, meaning when we actually now have to go and face a patient who is afflicted with this virus or any other pathogen under investigation. But one of the things I hope to communicate today is that we don't have to start thinking of IPC when we are in this situation. There are measures which we can do way before the situation gets here that can actually optimize safety. So in infection control, we have what we call a hierarchy of controls or a hierarchy of preventive measures. And as you can see, it is an inverted pyramid indicating that from the top to the bottom, you go from most effective to least effective. And I try to break this down into measures that help keep the threat out of the healthcare setting so that as clinicians, we working in a safe environment where these risks are minimal. But if these barriers are broken, then we will have to put additional measures of how we can manage or control the threat within a healthcare setting. And we shall talk about these in the next few minutes. So elimination and substitution, I will put them hand in hand. Elimination means you keep the threat away of your geographical area, and then substitution means that you substitute an activity with a much safer one so that your risk of infection as a healthcare worker or as a patient is minimal. So for example, by January of 2020, when we are still trying to figure out this novel coronavirus, what it is, the disease was way back in China, and most countries instituted travel restrictions to keep the threat out of their borders. That is the most effective one. If you listened to the president's address the other day, he did highlight that, the virus doesn't travel by itself. It needs people to move it. So by keeping people who potentially have a pathogen of interest away, then we should have no reason to worry about contracting it. Vaccination is another measure that has recently surfaced in our armory, and also a tool that has been used to control many other infectious diseases historically, including measles, yellow fever, and smallpox. And by vaccinating the population, then that means the potential pathogen or the virus doesn't have a means to transmit, because people can't catch it, and if people can't catch it, they can't transmit it or move it across borders. So vaccination in itself falls in this category of elimination and is a high impact intervention. Sometimes if people travel and contract the disease, we may ask them to quarantine, and you saw this happen last year, and that is also basing on the principle of elimination. Substitution can be used once we already know that the threat is within our borders, or even when we know that we have people who are sick within our community. And basically here you're trying to substitute high-risk activities that put you at risk with ones which are much safer. So for example, that's why we are having this webinar virtually rather than being somewhere in a lecture theater or somewhere in a conference room delivering this talk. Then some people might be encouraged, to commute to work using a bicycle rather than getting in a taxi or getting in a bus, because when you commute on a bike, you're by yourself and you're not at additional risk from other individuals, which is the same as teleworking, which also applies in the medical field. But once those measures have not held up and now the threat is within the walls of the hospital, then there are additional measures that have to be put in order to safeguard the patients and also safeguard the healthcare workers and any other individuals who work within that health facility. So engineering controls is one of the most effective in hospital measures because these ones work without even the healthcare worker doing anything. So for example, if I put a wall to partition ward A from ward B, that physical barrier itself is going to help contain infection to one wing, and that measure will work regardless of whether healthcare workers are, putting on masks, washing hands, or whatever. So these are effective because they eliminate the human element, which has its own challenges, as we shall see later. And for the SARS coronavirus 2, which is a predominantly airborne and droplet transmitted virus, then the key element for us to manage here is air. And the best practice would be that for an airborne pathogen, you have a pressure regulated room that is able to generate negative pressure. So meaning it's able to pull air within the room and contain it there so that any contamination from an infected person does not go outside. But we know that those are not quite available in our setting. And also for this being a critical care association talk, most of us know that the designs of our ICUs are, optimized to minimize traffic, to minimize noise, and to also, restrict access and, people peeping into the ICU. And the ideal place ends up being a room which is at the farthest corner of the hospital with probably no window, and perhaps we are using an AC there. Although those measures help us prevent other hospital-acquired infections like gram-negative sepsis, they make air management in those areas quite tough. So meaning if you look at majority of the ICU designs, they are not quite optimized for air management, especially by natural ventilation, which is the next substitute if we don't have pressure regulated rooms. Natural ventilation is basically opening windows and doors so that the air in a room is diluted by constant flow of air from the outside so that you can never have an infectious dose at any one time once you are in that place. The people who work in labs have also introduced, smaller biosafety modules, which you just put on a table, plug in power, and you have like gloves going into that box, and you can manipulate samples under biosafety level 3 or 4 conditions when you are just separated by a thin layer of polyvinyl or of polyethylene. And these ones have also helped scale up testing capacity as an engineering control in low resource settings. Administrative controls is where we actually have a lot of leeway to do much because here we are changing how patients and healthcare workers interact or how they go about their daily operations. So most of you at hospitals will be screened, or nowadays most hospitals will not permit visitors or more than one visitor per patient. And that is basically to limit the number of people that could potentially bring infection in a hospital. Staff training, which we are doing right now, as well as monitoring healthcare workers to ensure that those who become symptomatic or those who report being exposed are quickly taken out of circulation, not to put other people at risk. We have things like staggering of shifts, which ensures that if you have maybe 5 or 6 people on a shift, they are not all present at the same time. So the first 3 may come, followed by another 2, while the ones who came earlier go home, so that at any one time you have fewer people within the healthcare setting to minimize interactions. We can also increase cleaning frequency, suspending non-emergency appointments, and then exploring and implementing telemedicine consults so that patients don't have to come to hospital. And then also putting patients with a similar risk profile in one area so that you're able to control who moves into that area, so that those who are high risk are effectively kept away from the rest of the people who could potentially be at risk. And then finally, we know that much as we have dropped technology, for example, to have this meeting virtually, we haven't yet advanced to also be able to deliver healthcare at a distance, especially much of the clinical oriented work or the surgical oriented work that requires hands-on. So meaning at the end of the day, a healthcare worker will have to go to a patient. And then personal protective equipment, which is our last line of defense, comes into play. So PPE, being the last line of defense, is also the least effective because it has multiple human factors that play into how well it's going to function. It's highly dependent on proper use, availability, and then also how well you have implemented other controls like engineering and admin controls so that the best advantage of PPE is realized. PPE use should be guided by risk assessment and transmission dynamics. For example, we know if primary spread is through droplets, then we need to cover our eyes, mouth, and nose as the primary element of the PPE. Then secondary protection, knowing that transmission from fomites is also possible. Then we put on gloves, we put on aprons, we put on gowns, and we also wash our hands. We're going to discuss the role of coveralls in the Ugandan context later in the talk. So having put all those different controls into context, then you come up with an IPC strategy for how to combat healthcare-associated transmission of COVID-19. And these measures include, early recognition through screening, so that those who are eligible are put away in a separate area so they don't interact with those who are not meeting criteria. I will talk about the concept of standard precautions, which is the safety measures that must be taken for all patients at all times, regardless of their risk of infectious disease. Then we implement what we call empirical additional precautions, which are basically the additional measures that we must take, having known how the disease or the pathogen is transmitted. And then I talked about administrative controls, which are mainly to do with the role of the facility administration in ensuring that healthcare workers are safe, and then environmental engineering controls, which are modifications in the workplace that actually confer protective effects without the input of a healthcare worker. So this slide shows the main elements of standard precautions, but I've highlighted the top 3 because they play the biggest role, especially in this pandemic, which is a respiratory pathogen. So we have hand hygiene, respiratory hygiene, which includes, proper coughing and use of face coverings, and then appropriate use of personal protective equipment, guided by risk assessment. And that is another element that we are going to discuss later in the talk. But I also want to highlight the fact that injection safety, waste management, and proper cleaning and sterilization of equipment are also key, because it doesn't help for a healthcare worker to be protected against COVID-19, but they get HIV or hepatitis B from a needle stick injury. So even as you are attending to COVID-19 patients, these are ever-present risks, and we also have to be cognizant that of all the procedures we do, we should ensure that we are aware and we correct for potential transmission of blood-borne pathogens that could come from inappropriate management of these measures. So that marks the end of the milk session of today. Now we are going to talk about the meat of today. And I think one of the key elements that have guided or caused a lot of confusion, in best IPC practices, understanding where the virus is airborne or, transmitted mainly by droplets. And although, scientific literature classifies droplets, as, particles of fluid from the respiratory tract that are about, above 5 micrometers in diameter, then droplet nuclei are less than 5. In reality, when a person coughs or sneezes, they do not have a setting that flips the switch to let's produce above 5 and let's produce below 5. It is a mixture of everything. So meaning both modes of transmission do contribute to transmission of SARS coronavirus 2. However, depending on the situation, some modes of transmission will predominate, and in other situations, others will be diminished. So for example, when most people cough, or when people, project their voices, like in singing, they are most likely to produce droplets. And if anyone is in the vicinity, then these droplets could land on the eyes, in the nose, or could be easily inhaled, through the mouth or the nose, and then you have infection starting. But like I said, if we are in an environment which is dry and these droplets actually quickly lose their moisture, they quickly turn into droplet nuclei, and these ones can be suspended in air for longer periods and over longer distances. So meaning once you inhale these ones, they are even more likely to cause direct infection within your lungs, because the more tiny droplets are able to go through your nose, missing the nasal hairs, while droplets, even though they may be laden with more virus, they are likely to be stuck in the nasal hair and cleared. Also, it's important to be cognizant that environmental contamination happens this way. As I speak or as I cough, all the droplets that I produce, because they are heavier, they come down onto the ground much faster and they can contaminate it. However, we also have procedures where air manipulation of the air will lead to either forced expiration, or we have respiratory tract fluids being expelled at very high velocities. And these high velocities means your droplets are going to be drying up much faster and forming more droplet nuclei. And we call these aerosol generating procedures. And for example, you would say that those of you who have been to a dentist, if a dentist is using a drill in your mouth and you have COVID-19, that high velocity that's being generated by the dentist's drill is creating aerosols. Another example to consider is if someone is having high flow oxygen therapy, either by BiPAP or CPAP, or a high flow nasal cannula, or by a face mask that is not fitting properly, and you're having oxygen rushing in at these high velocities. If the mask is not sealed properly, then you also have aerosols escaping, and they can put people within the immediate vicinity at risk. I wanted to also discuss one fun thing that I learned over the past year with you regarding how does the respirator work and how does this play into our choice of masks. So, contrary to popular belief, a mask is not a strainer. It is not a kasenge jar we use at home for filtering chai, of which most of those are made of what you call woven material. So for example, this image on your left is showing you what woven material looks like. This is what the material in a cloth mask looks like. You just have fibers parting each other at 90 degrees, and this material is more breathable, means it makes the exchange much easier, but that also implies that pathogens can move through quite easily. On the contrary, a respirator is made of what we call non-woven material. So it implies that you have these plastic fibers put haphazardly and compressed together. So it's very hard for you to have a very straight path through a respirator. And respirators work by 3 different modes. So the first one is that if you have a large droplet, which is classified as, a diameter of more than 5 micrometers, then by the virtue of the fact that it is large, it is going to be trapped by the fibers of the mask, and it is going to be stopped right there. However, you also have these extra tiny droplet nuclei, which are less than 0.1 micrometers, or which are the ones we deem to be playing the bigger role when we look at aerosol generating procedures. These particles are so small that even when they are in air, they don't move in a straight line because they are bombarding off the other air molecules in the air. So something more like what we used to call Brownian motion in our elementary physics. And the advantage is that at this level, these particles are so sticky by a phenomenon called Van der Waals forces of attraction, that if they try to actually maneuver through a mask, the chances of them hitting one of the fibers in the mask and getting stuck is high. So these droplet nuclei are actually trapped by this mechanism, and the respirators are highly efficient at trapping these tiny particles using this mechanism. However, there are these particles which are somewhere in the middle. They are not so large that they can be trapped by the fibers, but also they are not so small, so they are able to actually move with the current. So meaning if a good mask should be allowing you to breathe, it means you still be having air moving through these fibers. And these middle-sized droplets or particulate matter is able to maneuver with the air current and is able to get to the person on this side. So when they are assessing the efficiency of a respirator, they are looking at how well it is able to keep out these middle-sized particles, and the percentage of those it is able to trap is what gives you the rank of the mask, such as N95 or N99 or KN95 or KP92. So meaning it is these middle-sized droplets which are in the middle that actually that are compromised when you look, or that compromise the efficacy of the respirator when you're putting it on. So, but the one trick that the masks have up their sleeve is that this plastic material, as you're breathing in and out, the plastic particles in here get charged. And when they get charged, these particles that are moving within the air, when they come close, they develop an alternative charge to the one on the fibers of the mask. So that charge is the one which attracts these large-sized particles, and helps entrench them so that they can actually be stuck within the maze rather than going all the way through. So although it is a very interesting mechanism, it can only trap a given percentage of the total load that is outside the mask. And we can eventually end up having a few moving in, but the question there becomes, do we have enough virus in this one particle to actually cause an infection? However, also, when you're looking at masks, there are some key basic elements which can either potentially shoot the role of respirators quite high or even reduce it. And one of them is an important fit. You know, majority of us didn't know that respirators came in various sizes until the COVID pandemic. And this is because some measures like fit testing for respirators are not done routinely. And also the people who procure these masks for the local market rarely consider the role of the different sizes of masks. So most people will have a respirator, but it won't be of the appropriate size. So if you're not having a proper fit and you have air escaping on your cheeks or under your chin, then air always takes a path of least resistance, and you will just be inhaling atmospheric air rather than air which is filtered through the respirator. Some of the questions around respirator use are to do with, you know, we know that these viruses or bacteria are carried on these respiratory particles, but are they actually viable? Or do we have them in a quantity high enough that if you have maybe 5% of the particles move through a respirator, they have an infectious dose to go ahead and cause infection? And then also the reason why cleaning of respirators is not highly recommended is that once you clean a mask with soap, alcohol, or bleach, then you are compromising the prostatic property of the respirator that is responsible for actually trapping those middle-sized droplets that actually cause majority of the exposure when you are using a respirator. I also wanted to share this graphic, which shows, you know, the different sizes of particulate matter and, you know, how they impact the efficacy of the respirator. So you have your pathogens down here, viruses and bacteria, but we are cognizant that it is very rare for a bacteria to say, I'm fed up, I'm leaving this host, and just bounces off by itself independently. No, these pathogens always go on cough particles. And you can see that the size of these cough particles is significantly larger than the pathogens themselves. So, you know, literature, or most of you must have seen images which give masks with efficacy of blocking certain pathogens. That is an impractical measure because we don't measure masks by how well they filter, you know, pathogens by type, but by how well they filter out particles which are suspended in air. This study further reinforces the role of fit testing for face masks. So please take these results with a pinch of salt, because this was a study in 7 participants, and each of these 7 people were given 7 different types of masks to try out, 5 of which were N95 masks, and 1 KN95, a surgical mask, as well as a fabric face covering. And you can see that each of these colors corresponds to a different participant. And on the y-axis, we have the fit factor, which is the measure of how well the mask is protective. And you can see that there is quite a lot of variation across, you know, different individuals depending on the product that they are using. And the authors were able to deduce that actually also, although most respirators fitted better, but you know, individual facial morphology also played a role in increasing or reducing the efficacy of a given mask. And also the one key finding was that in these 7 people, the fit factors for KN95 surgical mask and fabric respirators was basically the same. So there wasn't so much of a difference. So, you know, when you're in the middle of a second wave like we are, resources will run out, and there will be a temptation to consider use of cloth masks, especially for healthcare workers. And there is this study which came out in 2015 that tried to answer or give us insight into the possible role of using cloth masks in healthcare. And I think also before the pandemic, most health centers were using cloth masks, especially in surgical services. And in this clinical trial, which was done in over 12 hospitals in the UK, they either gave you a cloth mask, which is in black, or you were a control, you got nothing, or you were given a medical mask, or what we call a surgical mask here. And they were looking at the incidence of a clinical respiratory illness, or an influenza-like illness, or even laboratory confirmed viral illness by PCR. And it was shown that actually cloth masks were causing more harm, were increasing the percentage of people, you know, presenting with, you know, clinical respiratory illnesses, viral respiratory infections, or influenza-like infections across the whole board. So meaning cloth masks are even more harmful than doing nothing, especially if you are working in healthcare. And the authors here propose that, you know, because of moisture retention, or the fact that most of these cloth masks are reused and the poor filtration do increase the risk of healthcare workers developing these syndromes while using cloth masks. So that's why the use of cloth masks in healthcare may not be applicable, although we don't know how it would play out for COVID-19, but I think this study gives us indications to actually think in that direction. Therefore, for rational use of masks, respirators should ideally be reserved in areas where we are having aerosol generating procedures, and we can use N95s, facial piece 2 or 3, or N95, depending on the standard that you are following. And one of the challenges we've realized, at least locally, is that you always have one big COVID-19 ward where you have patients of different disease severity admitted. So meaning you can have severe, severe, moderate, severe, very critical, moderate, you know, all interspaced on one ward. So meaning if I'd wanted to say I'll put all my patients on CPAP in one room, then so that I only use respirators when healthcare workers are going there, this you know, big cohort ward approach where everyone is mixed means that it becomes impractical, because whether you're seeing someone who is moderately ill or someone who's critically ill, your risk of exposure to aerosols is still the same. Therefore, maximum benefit is realized if we cohort patients according to disease severity. The CDC recently revised their recommendation of using surgical masks as an alternative to respirators, even for aerosol generating procedures, because I think now they have enough stock or supply of the masks. But if we are to bring it to our context, if we are actually planning emergency measures for mask use in the event that respirators are out, then surgical masks with a face shield would be an acceptable alternative. Then all the other procedures that don't involve aerosols when we are caring for patients, a surgical mask is the recommended approach for respiratory protection. The other element that I'd wanted to discuss was, you know, the role of gowns or body protection. And this is mainly for safety from secondary transmission through fomites or exposure to body fluids. And we've also had studies and meta-analysis to help us evaluate, coveralls more, are they safer compared to gowns? And what has been found is that although coveralls confer an element of safety, they are more difficult to doff, where people contaminate themselves and create more deviations. But also coveralls mean the time for which you can work in a given area is limited because you sweat quite a lot, you can get dehydrated and you get tired quite fast. And also in this trial where they compared coverall-based PPE versus gown-based PPE, participants who had coveralls had more contamination versus those who had gowns. And then also the difficulty measured by the deviations in the doffing procedure were greater when using coveralls versus gowns. But also in the context of COVID-19, which is a primarily respiratory pathogen, then whichever you choose doesn't matter. So gowns would be equally as effective as coveralls, although depending on availability, then or even from a cost standpoint, gowns would be more cost effective since the cost of one gown is just a fifth of the cost of one coverall. So also in going ahead to contextualize, the use of body covering in our setting. This is a picture from Fort Regional Referral Hospital where I practice, and we're able to use linen or cotton material to make gowns that can be laundered. And this has the advantage of reducing the amount of waste generated for every shift, but also reduces the cost, assuming the lifespan of each of these gowns, after multiple washes is about 6 to 9 months. And that would translate into, we did an evaluation to look at what would be the cost benefit of using cloth gowns for just 2 of the major treatment centers and also ambulance services for 3 months. And the savings were, in the order of thousands of dollars. So another additional PPE considerations, like we said, because you're likely to actually have the droplets or any suspended particulate matter fall on you or fall on the environment. If you have a large hairdo, which will most likely be a mixture of woven or non-woven hairdos, then you're likely to trap some of these particles. And also in addition, even though it's not for just COVID, we could be carrying, residual transient flora or transient bacteria in our hair that we could, shed as we are providing care to patients who are at risk, like those who are immunosuppressed. So a hair cover, especially if you have hair, it would be recommended to prevent you from introducing more infection to the patient, but also to prevent you from sweeping up any particulate matter that could be suspended in the patient care area. Shoe covers and gumboots. So 2 schools of thoughts. Some people recommend that since we are taking a PPE posture, then regardless of where we are in the healthcare setting, we should be having shoe covers or gumboots at all times. But majority of the contamination on the floors has been noticed in places where we are definitively caring for COVID-19 patients, like isolation wards and ICUs. So in those areas, shoe covers or gumboots are recommended. But if I'm taking samples at OPD or if I'm doing screening, then I should do just fine with my normal shoes from home, which should typically be covered at that pause. Aprons can be used where body fluid exposure is anticipated, and like in the case of the cotton gowns that I showed earlier, because they are not waterproof, then an apron will also come in handy to limit the exposure to body fluids in case of splash. So I pulled these infographics from a WHO manual for risk-prompt healthcare workers, and PPE can therefore be classified into 3 main blocks, whereby the first one here on the left is where you have a surgical mask, and this is for when you are interacting with patients without touching them. This could include when screening patients or even taking history at a distance. And if you need to come closer, you can add a face shield to protect against the risk of droplets or aerosols accessing your eyes. Then you also have instances where you are actually caring, meaning you've gone from just talking to also touching the patient. And this will include, taking samples, transferring patients, providing care and examining them. So all those activities, we want to keep our surgical mask, we put a face shield, and then also to avert the risk of body fluid exposure and environmental exposure from where the patient is, we put a gown, as well as a pair of gloves or 2, depending on the local recommendation. However, if any of these activities where we are caring for the patient, now we have aerosol generating procedures as part of the continuum of care, then we substitute the surgical mask with an approved respirator to help avert that risk. Face shields and goggles can be used interchangeably. Each of them has pros and cons. Goggles form a nice seal around the eyes, so you can be sure that you won't have anything sneaking up on you, but they leave the mask exposed. Yet you can see a face shield covers both your eyes and your mask, which limits the number of respiratory particles that go ahead to contaminate your mask over the course of the period that you're giving care. But both of them are recommended depending on what is available. I wanted to talk about a few things or a few principles regarding infection control at home. And I think one of the reasons why it's actually hard to give a recommendation in this area is because no one is going to come in your home to tell you how to run your house. Once people are in their homes, what they say goes. And that's why it becomes quite hard to recommend best practice in homes for IPC. But I wanted to share these 4 main principles which can be utilized, especially in homes where you have a family member that is isolating at home for home-based care or even quarantining following exposure. And the first thing is, stay home if you've been exposed, or if you're having someone within your household who is ill. We no longer recommend the idea of isolating within a home as individuals, but you actually isolate as a household. So it's a bubble of a family that is isolating together for that given time period, because we are cognizant of the fact that it is very hard, for example, to have a bed, a toilet, a kitchen that is exclusive for that individual who is being isolated. So you isolate as a bubble, and during that time, you stay at home and you don't accept visitors so that you minimize chances of community spread. Cover your cough when you cough or when you sneeze, or we also recommend that you use a mask if you have a sick individual within the household. This applies both to the sick person as well as to the family members whom they're isolating with. Minimizing clutter, this is also subjective. People might come in my house and say it looks quite disorganized, but I know where to find everything. But if you look at it from the context of how easy it is to clean, then cleaning the environment is much easier if you have less items scattered within that area that you're trying to clean. And you might need to clean, surfaces which are touched commonly, like door handles, a remote, or a table where we share a meal. Those are high touch surfaces that should also be cleaned more frequently, especially if you have someone who is under home-based care. And also, just as in hospitals, wash your hands while you're at home. And so, although some of the points where we wash our hands are geared towards preventing diarrheal diseases, those should be maintained, but also routine hand washing, especially after interacting with the person who is under isolation, or after being in an area which we share most, like a dining table, then washing hands will also go a long way in minimizing the risk of acquiring the virus when you have someone sick at home. So behavior aspects in infection control, this is also a whole other broad area. And we totally understand that, like during this pandemic, where you have high chances that things are going to run out, or the fact that a healthcare worker who has come to duty that very day has probably lost someone they know over the past few days. So there are very many factors that play into our behaviors, or what we've seen on the news or on social media. All these things go into our subconscious and influence how well we implement IPC practice. But some of the things that have been demonstrated to actually improve or to leverage behaviors to increase IPC compliance is leadership. So, for example, most of us, when we are undergrads, we are aware of lecturers or teachers who explicitly said that, if I am 1 minute ahead of you in my class, if you're 1 minute late, don't bother coming. Or if you come to my ward round without a tie, I'm going to send you away. And they set that precedence, and as leaders, we were able to, as leaders or even as students, were able to move into that recommendation. And doing the same for IPC, encouraging people to actually wash their hands, to put their mask on their nose and mouth instead of keeping it on the chin, or encouraging people to put on cloth masks when they're out in the community. Having some of those visible, strong leadership qualities for best practice in IPC go a long way in increasing compliance in a given circle of healthcare workers. And also staff morale and well-being has a role to play. Like I said, these are really tough times. We are in the peak or approaching the peak of the second wave, and people are tired, or people have gone through a tough experience with either a family member or a friend. And sometimes that lack of motivation or morale makes someone more likely to have lapses in IPC practice. Therefore, small things like, a small thank you can go a long way in motivating people to actually do the best thing. And then also it will, a motivated team will be free to speak up, so that it's not only the nurse and the resident who have to wash hands and put on masks, but also they can ask the section head or the supervisor and say, hey, I think, sir, you had a lapse here. You should perhaps put on your mask, or you should change your gloves, or something like that. Education and training is important. I'm glad we are having this didactic session online, but also one thing people have to know is that once you have learned what to do, IPC now becomes a motor competence, meaning it's like being a surgeon. You learn or you become more experienced the more you do with your hands. And it's the same with IPC, knowing that I have to put my mask on or to wash hands after doing this or to, keep my face shield in this area, not to walk through this area which has been restricted. All those are motor skills, and you can only appreciate them the more you practice. So education and training should be both at a practical perspective, but also learning the science behind. Risk perception, and this, I think we have seen it play in the biggest role in this season when we have had vaccines available. There is a lot of conflicting literature or a lot of information that is, coming at an overwhelming speed that we are finding trouble to internalize it. But the best approach is that, as healthcare workers, you should know that whether you're young, healthy, without comorbidities, regardless of all that, you are, 3 to 4 more times at risk of contracting disease than someone of your caliber in the community. So taking these measures should be of utmost importance to us as healthcare workers, because our risk profile is different, and we should endeavor to be safe rather than being sorry later. One of the key things that has emerged over the past few months that we are trying to incorporate into our IPC programs, both at hospital and community level, is, vaccinations. They are effective as an elimination strategy, which is, a top tier intervention. And, by having fewer infections coming in or fewer admissions and ICU admissions happening, then that way we are saving healthcare workers by lowering the risk of healthcare transmitted COVID-19. But also, as we've seen, PPE is the least effective measure, and is the last one. So if you have vaccinated staff, then any gap that is left by the inherent shortcomings of PPE will be covered by the fact that this individual is vaccinated. And, we should be able to provide care using low fidelity PPE without significantly increasing the risk of the healthcare workers that are participating in care. So once again, the key message is, think of infection control from the moment you wake up in your house, as you commute to work and all the way into the hospital, and also be cognizant of the fact that proximity is a key element. Whether a virus is droplet or airborne, the whole point is that if you are within the vicinity of someone who is infected, especially for longer times, that alone is going to significantly put you at risk of infection. PPE is the least effective measure and the last line of defense for IPC. So it's important that we make investment in all the other measures before we have to come to PPE, so that we keep ourselves and our patients safe. It's good that we are having this talk to disseminate information, and increasing risk perception can be built through reading the literature from credible sources, and then also try to vet each and every thing that is presented to you as a fact or as science, so that when proper interventions come, you don't miss the boat while you're still on the fence guessing of am I for or am I against? So with those very few words, I'd like to say thank you, and I'll be glad to take any questions from the team. Thank you.
Rodgers. Sorry, thank you, Rodgers. This was a very educative talk. We have a lot of questions already, so we'll just start with a few. Please take a minute to sip some water while I go through some of the questions here. Okay. So first, about masks. what's the science behind double masking in a healthcare setting? And do you recommend it in the community?
So the science behind double masking was that we came from CDC, and this was basically based off lab studies that were done on mannequins. So they put double medical masks or a cloth mask plus a surgical mask, or twisting the strands of the surgical mask so that it fits more snugly on the cheek. And then they artificially generated pressure or simulated a cough or a sneeze to look at the effectiveness. And it was, and as they saw in the lab-based trials, double masking either with a cloth mask and a surgical mask, or with two double masks, let out fewer particles. But because the experiment was done in a lab, it is hard to appreciate how well it's applicable in a real-world setting, because a good mask should not just be good at filtering, but should be able to allow you to breathe. And that element, which is subjective which is subjective to doing the experiment in humans, wasn't reported. So eventually the CDC revised the guidance, and they say that if you are in a community where you likely to be in a congregated setting, you can use a cloth mask and a surgical mask in combination while in the community, but while you are in a healthcare setting, then a single surgical mask should suffice, because double masking using two surgical masks is not practical, it's expensive, but also surgical masks are not built for filtration. So because they do not fit, whether you put two masks, like I said, air takes a pass of least resistance, you'll still be inhaling some of the particles from the gaps in your chin and your cheek. So bottom line, I think we need more information and wouldn't recommend it for this time. Over.
Okay, thank you, Rodgers. That was a question from Keith Kakame. Something else about masks. This one is from Ronald Bisegira. About the mechanism that you described of the respirator and the negative charge being formed in there. Does that mean that is that negative charge created by me breathing in? And if so, does that mean that I have to breathe in? I have to breathe in for some time before going to the CPU to create that negative charge?
I wouldn't say I have a definitive answer for that. But indeed, if you see the way CT operations are made, you don from a separate area before you prepare to go and see patients. So I believe that is enough time for any charge to have been generated. But then also the other thing we have to know is that most of these droplets themselves, because they have been floating in air, will, by virtue of that, develop some charges which help induce complementary charge in the mask that increases the stickiness so that those small particles are caught. So I hope that response suffices.
Sorry, for anybody who missed that, this session has been recorded and the recording will be shared on our website. I've written it in the chat. So you can get it from the chat and you'll check it out on the website. The part about the respirator was a very good reminder of physics and how the mask has some physics as well. Yes, still about masks. What's the risk involved in reusing an N95? And since we are in now a resource limited setting and, second, a huge wave going on right now, we are probably going to have to reuse them. So how can we reuse them safely? Can we microwave them? Since we talked about washing, taking away that electrostatic mechanism. So can we microwave them at least?
Wonderful question. And I think one of the challenges we've had is that we haven't had any national guidance on how to reprocess respirators. So most hospitals have developed local protocols for doing that. One of the protocols that I have seen is that, you know, you're given a respirator to use for about 3 to 5 sessions. So meaning if you're putting it on for a shift, it can go for 3 to 5 shifts, which is an approach that has also been used in TB care. The risk there is that your mask, because it is actively filtering the air for particles carrying pathogen, then you're likely to have a lot of virus loaded, especially on the outer side of your respirator. So one of the approaches has been that when you take off your respirator by holding the straps, you don't touch the front side, which is white or green, and you put it in like form of a bucket. So like, you know, a small plastic dish, the ones we use for carrying lunch. So you put it in there and you close it. And so the whole aspect is that you don't want to contaminate your hands while putting it off. And by keeping it in a closed container, then you limit people, you know, touching it inadvertently and picking any soiling from it. The advantage of also doing that is that if I keep it, you know, for the next 12 or 16 hours before I use it again, then any moisture in there should have evaporated so that the virus is, you know, left dry. And if the virus doesn't have a medium to survive, it will break down much faster. So that is the premise behind some of the measures as such. Use of microwaves has been tried out, but was also found to, you know, damage the filtering mechanism of the respirator. Some studies have used the ultraviolet light, band C, and this one is that purple light that you see in biosafety cabinets if you've been in the lab. So, you know, you put your masks under that light for about 4 to 6 hours, and ideally they should be disinfected. But the best approach would be to rationalize what we have so that we minimize reuse, because regardless of whether we reprocess the respirators adequately, it's been shown to be associated with increased healthcare worker infections in epi studies done in the UK. Over.
Thanks, Rodgers. Also, in a CTU, if I have a fitted N95 mask, do I really need to wear a surgical gown?
Yes, if you are expecting body fluid exposure. The whole basis for wearing a gown when you are in an ICU or a CTU is that while you were away, this patient has been talking or coughing or breathing fast, generating droplets that are contaminating their most immediate environment. So if you come with just a respirator and you still, you know, go ahead to examine the patient without protection, there is a theoretical risk that you could potentially rub off the patient's environment and pick some of the virus from there. So that's the reason why, you know, despite putting on the respirator, a gown will also be required. Remember, you know, you have primary transmission, which is through suspended particles in the air, and also secondary transmission, which could be from the patient's environment, either using hands or, you know, us rubbing against or leaning against the environment that's contaminated. Over.
Okay, thank you. Let's see. So, Rodgers, in Uganda, have there been any studies conducted on health worker IPC practices? I think that's more specific for this COVID-19.
Yes, so we've had studies done mainly in lower healthcare facilities where we expect most patients to present when they fall sick. And we also have additional Ministry of Health led efforts that are doing infection prevention and control, enablers assessments, and healthcare worker compliance in the primary healthcare facilities. So the premise of doing the study in that population is that once you safely manage the first presentation of a patient to a healthcare setting or to a healthcare worker, then the best controls will be implemented throughout the referral process until they come to the national referral hospitals. So there is work that has been done in Uganda, and I think was published in British Medical Journal last week. And it was basically a comparison of, IPC performance in Uganda and about 12 other African countries in this time of the pandemic. And these other additional assessments will also be perhaps published before the end of the year.
Okay, thank you. That's good to know. I hope people check it out. It said British Medical Journal, and it's quite recent.
Yes.
So another question about the CTUs. Is there a risk of transmission if we are sharing equipment among patients? For example, BP machines, pulse oximeters?
Yeah, thanks for that question. And the answer is yes, there is a risk of transmission. And one of the other administrative controls that I mentioned was putting patients in cohorts. So meaning if I'm having COVID patients in one room, then even though I use that BP machine on them, since they all have COVID, I cannot possibly reinfect someone by using that same BP on them. However, if I move a BP machine or a pulse oximeter from an infected patient to someone who is not infected, then indeed there is that risk. However, as part of best practice from standard precautions, even when I use an equipment in patients who are within the same risk category, I have to disinfect it as per the manufacturer's recommendations before I apply it on the next patient. So meaning if I'm using an auxiliary thermometer on one ward or a pulse oximeter, then I should be wiping it with either an alcohol wipe or an alcohol swab before I put it on another patient. BP cuffs are of a special interest because I think the need to disinfect between patients always translates into dipping majority of these BP cuffs in alcohol, and they break down quite fast. But because you're putting the BP machine on intact skin, then you may not necessarily have to disinfect it in between patients. And the manufacturer recommendation is that you could clean it weekly by actually washing it in soap and water, since most of the properties of the material that make that BP cuff are not suitable for use with ethanol or isopropyl alcohol. Over.
Okay. Thank you, Rodgers. I think that was a good question because it's good for us to remember that even in the COVID unit, there's risk of infection transmission between patients. And it's not like, oh, these are all just sick COVID. I don't need to sanitize. I think people easily forget. And, since you're very worried about protecting yourself, you forget some of those things. There's a question about face shields. you mentioned face shields later on when talking about coveralls. So are they so important in clinical practice? And for people who wear glasses, if you had mentioned that face shields are important for protecting your eyes. So if I wear glasses, are they enough? Over.
Thank you so much for that question. And I will answer it in two parts. So face shields and goggles play the same role and are both equally advantageous. But like I said, each has advantages and disadvantages. Goggles are advantageous in a sense that for them, they form a seal around your eyes. And they always have that strong elastic band which you put behind your head. And the advantage there is that even though you have turbulent airflow in the area where you're working, you're still protected. You won't have anything seeping through and coming to your eyes. But the disadvantage is that because they form a seal around your eyes and your skin, when you sweat or perspire, then all that moisture is going to condense on the visor and you get a phenomenon we call fogging. And for some people, it can happen as short as 5 minutes. For others, it may take as long as 1 hour to happen. But that's the other downside. Face shields are open at the bottom and on the sides. And you see they act on the premise that the infectious particles are going to move in a straight line, which is not always the case. And you always have turbulence, so you can have air coming from under or from the sides to reach your face or to reach your mask. But the advantage is that because for them, they don't fit tightly, they don't fog, and meaning you have better clarity. And also because they are long to cover the face, then you also have the advantage that your mask is protected from some significant amount of contamination by any droplets which are in the air. Therefore, for all healthcare workers who are seeing patients during this time, a face shield becomes critical. Just as we are saying all healthcare workers should wear masks, having a face shield will help increase the efficacy of your mask since respirators are scarce, but also it will enable you to work longer with clear vision without the risk of fogging. Over.
Thanks, Rodgers. What about for like spectacles, like mine?
Oh yeah, sorry, I'd forgotten about the specs. So if you have specs, it's best that you use them, whether you're using a face shield or goggles, because I understand once we take away the effect of the lens specs, then still, even though the face shield is clear, your vision won't be perfect. Some of the innovations that have been proposed was to have a plastic band that secures your specs on your head, and then you can put your goggles or face shield on top. So whether you're using goggles or face shields, please endeavor to keep your specs on, because you need to also have good acuity to provide care.
Mm-hmm. Thank you. We have a question still about the mask and the charges on a mask. So someone is asking, if the negative charge is generated in the mask, shouldn't it repel the particles instead of the particles being stuck to them?
So it would repel the particles if they are carrying a like charge. So if they are so by virtue of the fact that the body is charged, any material that is able to generate charges will by default have a negative, an opposite charge generated in it, so it can be attracted. So it is the way the physics works is that if I bring a body without charge close to a body with a positive charge, then the positive charges in this uncharged body will be pushed away and the negative ones will come on the surface, leading to that attraction. So it's like magnetism, like charges repel, like charges attract.
Yeah, okay. Thank you, Rodgers. So once again, guys, the description of that was in the earlier for people who joined late, but the presentation and the webinar has been recorded, so you can just access it on the website. It will be posted soon. I don't think we have any more questions. There's someone in the chat. Okay. Rodgers, anything else you want to say?
Well, maybe the one last message I'd like to say is that, thank you to all the healthcare workers for the role played in helping with this pandemic. Please wear your masks, wash your hands, and physically distance. One of the missed opportunities that we are afraid of getting disease from the patient, not knowing that even interaction with colleagues, with healthcare workers, and also lead to healthcare worker transmission. And also for those who are not yet vaccinated, please give it consideration. You won't regret. Thank you.
Okay, thank you, Rodgers. This has been a really lovely presentation. You have given us a reminder of all the things we had forgotten or taken for granted since the pandemic had relaxed a bit. But now I hope we'll be geared up from all this, and I hope we've all learned a lot. Thank you so much for coming to the AAU. Unfortunately, I don't think we can persuade you to join us anymore. You've gone down the rabbit hole in infection control.
It's not late. It's not late.
It's not too late.
Yeah.
Is there any way for people who are interested in infection control and IPC to learn more, like short courses and all that? Does the ministry offer those?
So the ministry hasn't drafted a curriculum to incorporate IPC into biomedical training in the country, but there are international courses that can be taken, and you get an internationally recognized credential in infection control, and it's so broad, so it's applicable to clinicians, nurses, pharmacists, lab personnel, or even people in facility management. And I would be happy to come and talk about that another time.
Okay, thank you, Rodgers. So once again, thank you all for attending the webinar. We appreciate all of you. We hope you are safe wherever you are. Thank you all for your work. The AAU wishes you good health, and for yourself, for your families, for your patients. Remember, we are all in this together, this pandemic. Keep up the good work. Don't be discouraged. And once again, the presentations will be shared in the recorded version of the webinar. You can check it out on the website or on YouTube as well. We have the YouTube channel where it will be posted. So thank you all. And just a reminder, there are some masks available at the AAU office for members who are fully paid up, unfortunately. So just get in touch with Faith and she'll tell you more about it. So for everyone else who's not part of AAU, thank you so much for joining us. We hope you'll join us in the future for other webinars. And yeah, thank you.
Thank you.
Wish you good health. Thank you, Rodgers. Thank you so much. Thank you, everybody. And this is the end of the webinar.
All right.
Okay, bye.